nuclear medicine. Nuclear medicine. It's a branch of radiology. Utilize the pharmaceutical agents labeled with the radionuclides to visualize the organ and treat diseases. Nuclear medicine is used in nephrology since 1960. Radionuclides, the photon emitting imaging. Radionuclide used technetium-99 and iridium 111, and positron emitting imaging. The radionuclides used are carbon-11, gallium-68, fluorine-18, and iodine-124. The radiopharmaceuticals, they are divided into three groups based on the mechanism they excreted: glomerular filtration, tubular secretion, and tubular retention. The pharmaceutical agents which are excreted by the glomerular filtration are DTPA and EDTA, and tubular secretion tubular secretions, and these pharmaceutical radiopharmaceutical agents are MAC3, OIH, and EC, and tubular retention. These radiopharmaceuticals are DMSA and GH, galactoheptide. Technetium DTPA. The excretion fraction is 20% approximately. For this reason, not useful in patients with the impaired renal function. In such cases, the agent with a higher excretion efficiency, such as MAC3, is more appropriately used. In a 10% plasma protein binding, so it tends to be underestimate the JPR, which is non-significant. In technetium MAC3, the characteristics are 70 to 90% protein binding capacity, 89% secreted by the tubules, and 11% glomerular filtration. Extraction fraction of 40 to 50%. They provide the high target to background ratio, good image quality, and more accurate numerical value, particularly when kidney function is low or mature. That's why it's the agent of choice. Cortical agents, technetium DMSA, which is used to find out the pyelonephritis, infarct, scar, or anomalies. The characteristics are 75% protein binding in 6R, and 5 to 20% excretion in 2R, and 37% excretion in 24 hours, and 45 to 50% cortical localizations, and maximum activity at the 3 to 6R, and 2 to 5% millicurie IV dose is the dose, and image taken at 2 to 4 hours of duration. The scintigraphy. The scintigraphy, it's a diagnostic test which is used in the nuclear medicine. A radiopharmaceutical agent injected internally with a peripheral band, and they emitted and goes into circulation, and radiation emitted. And this radiation activity is captured or detected by the external detector unit, such as gamma camera, then formatted as an image. Scintigraphy techniques. There are two techniques: single photon imaging and PET scan. In single photon imaging, 2D scintigraphy and 3D scintigraphy, or also known as Sahab. In 2D scintigraphy, the radionuclides that emit low energy gamma photons, and these gamma photons are detected. These gamma photons are detected at a gamma photon detected. This gamma camera detected by the detected photon at a single angle of the patient, and ultimately acquire the 2D images. In 3D scintigraphy, required the gamma camera to be slowly rotated around the patient. The photon can be detected at the multiple angle, and the acquired 3D images using the tomographic techniques. The PET scan explained in a slide later on. In a renal scintigraphy, in this, the radionuclides injected in a peripheral band, which is circulate and reach into kidney, where in a kidney, the radiation emitted, which is detected by the gamma camera, and ultimately images. The indication of the renal scintigraphy, the renal perfusion or renal function, and urinary tract obstruction, renal vascular hypertension, infection or renal scarring, renal transplantation, or to find out the congenital anomaly masses. Basic renal scan procedures. First step is patient preparation. The patient must be well hydrated. Give the ester 5 to 10 ml per kg fluid over half or 1 hour by oral or with injectable. The patient must be well hydrated. Apart from that, if the patient tube is present, it should be clamped or boiled before the injection, or if not able to boil, then catheterize in a patient with history of the bladder obstruction and neurogenic bladder. The image acquisition, the patient supine position preferred, and in a vascular phase, the rate of image acquisition is 1 frame per 1 or 2 seconds over the 1 minute, and in a functional phase, in a slower rate of 1 frame per 1 minute. In a dynamic renal imaging. In our dynamic renal imaging, the evaluation of the renal blood flow and the function of the native kidney, the posterior projection is taken, and in a transplanted kidney anterior projection is taken. And in a perfusion imaging, in a dynamic renal imaging divided into 2 phases, in a perfusion imaging and functional imaging.
आपने कितनी बार इसको प्रेजेंट आपने खुद किया 10 बार किया जैसा मैंने कहा था आपको presentation. If you just read these lines, there is no point in giving a presentation. ये तरीका है presentation करने का. आपको पता तो बहुत महीना 1 महीना पहले से था ना. आपको सुन रहे हैं. Don't have to be nervous. You just tell me what is the reason why you were not able to prepare it. Why you people are not taking it seriously? और आपने 15-20 मिनट पहले आके पता क्यों नहीं किया कि चाबी नहीं है? Try to shorten it as much as possible.
In a perfusion phase, the value of the pharmaceutical agents, IV and antivital when injected, and the imaging renal perfusion usually begin as soon as the radio vessel is seen in the abdominal aorta. Subsequent images are taken every 1 or 2 seconds. In a normal blood flow, by 3 seconds, aorta is fully visualized, and by 5 to 6 seconds, both kidney are seen. Maximum kidney activity reached in a 30 to 60 seconds. This is a normal DTPA scan where the aorta initially seen, and later on the aortic may disappear and renal shadow appear. In a functional imaging, at the end of the perfusion sequence, the imaging of the function begins. The maximum parenchymal activity is seen at the 3 to 5 minutes, and activity in the collector system is better by the 4 to 8 minutes. This is a normal DTPA scan with the perfusion with the functional state. Renography, also known as sign activity curve. This is a graphic representation of the uptake and the estimation of the radiopharmaceutical. Information is displayed from the time of the injection with about 20 to 30 minutes. Renogram divided into 2 phases: vascular phase and functional phase. The vascular phase lasts for 30 to 60 lasts for 30 minutes, and parentheral phase maximum activity seen at 3 to 5 minutes, and the uptake every 1 minute full state function, and washout phase low activity after 30 minutes. This is a rheogram or time activity curve. In this graph, the vascular phase, this is 30 to 60 seconds. Then 3 minutes is a phase, and peak activity is around 3 to 5 minutes. Then venous phase and radio pressure workout. This is a BTPA scan, where in upper graph there is a perfusion phase. In this the activity it is the aortic graph, which is shown in the black curve, and this is characterized by the upstroke, and in a normal perfusion phase, the left kidney and right kidney curve should be in a parallel to the aortic curve. In a lower graph, there is a perfusion phase where there is a initial left kidney curve and the right kidney curve, or there is a rapid uptake, and then a peak activity, then from fall. Diabetic renal scan, or indication of the diabetic renal scan is to evaluate the functional significance of the hydronephrosis to differentiate between the objective and non-objective hydronephrosis. In principle, the hydronephrosis, the vessel pulling in the dilated system pelvis, induces increased urine flow, and if obstructed is more than will not wash out. If dilated, then or non-obstructed, then wash out is C. And prerequisite, the residual function to respond. The residual function of the kidney should be is a prerequisite for the renal scan, and diabetic given 15 to 20 minutes after the radiopressor injection. And it's a dose in the infant 1 milligram per kg, in children 0.5 milligram per kg, and in adult 40 milligram. There is a half clearance time. The half clearance time is a time which is required to or half deep or radiopressor clearance. Half of the radiopressor cleared from the pelvis. If the half clearance time is normal, if it is less than 10 minutes, it's a normal. If it's more than 20 minutes, it's normal. If the total indeterminate. This is a renogram curve, which is showing one curve has a fixed uptake and peak and from fall, and another curve has delayed uptake and delayed peak activity. Then after using the diabetic, then it from fall, which indicate the non-obstructive hydronephrosis. In this renogram curve, after using the diuretics, there is no fall or peak, or there is no fall, which indicate the obstructive hydronephrosis. This arrow indicates the use of the diet. Orally curves, which showing the tennis pattern. It is of 4 types. In a type 1, there is a quick rise and a peak activity, then quick fall. In a type 2 curve, a quick rise, and after using the there is no peak, but after using the diuretics, there is using the curve which indicate the complete obstruction. In a type 3 curve, after using the dialysis, there is a round wall which indicates the non-obstructive, dilated. In a type B, after using the dialysis, the after using the dialysis, neither the keep raising the curve or not the from fall. So this condition is indeterminate or irrevocable. In type 4, in a type 4, after using the dialysis, there is the from fall, then again rise. So and type 4. There is an additional application of the MED3 and DTPS scintigraphy. These are one is capillary renal scan. On a capillary renal scan, the DTP before of the MED3. There is a protocol in a first day. There are baseline scan there, and then after administering the capillary, then scan both capillary scan. And if it is not, if it is abnormal, then on after 48 hours, another scan will get. Abnormal capillary renography or abnormal capillary scan, the delayed, which is characterized by the delayed time to maximum activity. If delayed time to maximum activity greater than 11 minutes, and significant asymmetry of the peak activity of each kidney, as you saw in this slide, and a mass decrease in the GFR of the related kidney. The capillary renal scan. In this scan, the capillary renal group, the time activity curve. There is a marked asymmetry between the two graphs, and delayed uptake and low peak. Another is the most sensitive scan available for the CA prostate. For the CA prostate is correctly identified 85% of the men with metastatic tumor compared to only 38% for the CT and bone scan. Indication is biochemical recurrence after the radical hysterectomy. Second is high-risk prostate cancer that appear localized, no tumor seen in the CT or bone scan. In CA testis, the use of the PET scan only in the metastatic testicular seminoma to assess the post-chemo mass, and BC PET scan. In a CA case, in determining the extent of the nodal involvement in a patient is only partial nodal lymph node. And the role of the PET scan in the kidney cancer, men unclear, and in the uterine cancer, men unclear. Yeah. Why the time check is not coming? एक बार नीरव देख नहीं आ रहा अच्छा इसमें ये कर रखा है. So
If any resident or faculty member has anything to say, any comment to make, please go ahead. I can see Dr. Kim joined. Thank you, Dr. Kim, for joining us, and Dr. Sumit, Dr. Anurag Yadav, and many people. I'm really sorry for today's presentation that we could not start in time, and there was some hindrance. I'm sorry for that, but if any of the faculty who have joined from outside has any comment to make, please go ahead. And any of the faculty from our department. So to summarize, I will just give a brief summary before we get some queries or questions. Otherwise, we will wind up the session. So we all know that this radionuclide imaging is important because we need to have, besides the anatomical imaging which we get from CT scan and MRI, ultrasound, etc., we need to have a functional study of the organs. And nuclear imaging would help us in the functional aspect. And the two things are very important here. One is a radiopharmaceutical agent, which will help us to target the particular organ. And the other thing is the radionuclide agent, which will actually is tagged to that radiopharmaceutical agent, which will help us in the imaging, because there is a gamma camera which will help to detect these rays which come from these radionuclide agents, which are tagged to that radiopharmaceutical agent, which get concentrated in that particular organ, and then we get the functional imaging of that particular organ. So amongst the radiopharmaceutical agent, we have what are the agents? If you can, some of you can mention radiopharmaceutical agents. So we know in renal scan we use DMSA, then DTPA, then MAG3, then FDG is used, then PSMA is used for CA prostate, right? Similarly, radionuclide. What are the radionuclide? Technetium 9M, and then for CA prostate, gallium 68, and then F18 fluorine for FDG with, right? So this is important for the functional study. Similarly, now we can have a fusion of both anatomical imaging and functional imaging by doing kind of a PET CT, where you combine the two, right? Similarly, PET MRI can be done to combine both anatomical and functional imaging, right? Similarly, there are some advances in MRI also, where we can have a functional MRI, like the ferromagnetic particles and the lymphotropic MRI, where we can know very exactly whether the lymph nodes are metastatic or non-metastatic, right? So then the next way forward is the molecular imaging. So the molecular imaging will tell you exactly not only the function, but also the type of cells, whether they are benign or malignant cells, right? And any advances you know about the nuclear imaging? Any newer advances? Anybody? Huh? Anybody? Any newer advancement? Nobody has any other question or comment to make? Like in CA prostate, we have PSMA with gallium 68, where you can do PSMA PET CT, which is coming up quite fast and could be nowadays only in guidelines we have for kind of to know in the follow-up studies to know the recurrence, biochemical and organ recurrence, but it is also being slightly used for now diagnosis also, right? Similarly, in the bone scan, there is a newer molecule which is being used. Then any other organ you think where the nuclear imaging is used besides prostate and kidneys? Any role of nuclear imaging in bladder? Adrenal gland for pheochromocytoma, which MIBG scan, right? Wonderful. Anything else? In testicular tumors? In testicular tumors, the only role is probably to know if there is a residual mass after in a seminoma, after giving chemotherapy or radiotherapy. If there is a residual more than 3 centimeter, then probably PET CT might help. Anything else? VUR, yes, wonderful. So in vesico-ureteric reflux, particularly to have a follow-up of this vesico-ureteric reflux, and you know this dose radiation that you give in for this VCUG when you do with radionuclide scan is 1% of what you have to give in normal VCUG. So that is why it is very important to do it in follow-up once you know the diagnosis. Yes. Anything else? One is yes. Yes. So one of the important aspect of nuclear imaging is not only for diagnosis but for therapy also. Similarly, in CA prostate, we can actually give therapy. 68 gallium PSMA ligand bound with lutetium is being used for treatment of metastatic CA prostate. As he said, actinium also. So all these are very important things to know about nuclear imaging. And anything else you want to add? In renal masses, there is another important molecular imaging that has come up, which will help to differentiate between benign tumors and malignant tumors, particularly oncocytoma from RCC, right? That is SystemAB, MIBI scan, right? And anything else? So I think that's it. If any of the faculty member has anything to say, Dr. Anurag, I am saying yes, your hands up. Please go ahead.
Yes, yes. And Dr. Shivam, I just wanted to know your comments about the role of DTPA renal scan when the creatinine is high. Maybe if the creatinine is 3 and both the kidneys are having compromised renal function, how do you study, how do you interpret the DTPA renal scan and the split function?
Yeah, this thing we in one of our initial classes we had a whole talk on nuclear imaging from one of the very renowned consultant in our own city. In that he said that usually even if there is a high creatinine, it doesn't matter when you're doing a nuclear imaging. So even with 3 or 4 creatinine, you can very well go ahead and do a nuclear imaging. That would not make much of a difference when you are doing a renal scan.
Okay.
So the renal scan will tell you exactly the function even if the creatinine is high.
Okay.
Anybody has any comment to make on this? So what do you think, Dr. Anurag?
Yes, I also agree. I also agree, but I had heard a few people saying there's no role. Do not go ahead with this or do not interpret split renal function if the creatinine is 3 or more. So, but I go ahead with the investigation like that, even in the creatinine is high.
That's right, because there could be some fallacy because of the overlapping of this uptake from the surrounding and in the organ. So that may give some fallacious result, but otherwise I don't think there should be a problem, even if it's a raised creatinine doing a renal scan. Yes. Anybody else has anything to say? I can. Yes,
Shivam,
yes,
good
Dr.
morning.
Kim. Go.
Yes.
Good morning, sir.
Yes.
Good morning.
Two indications which will come low, way down in the list. One is for transplant to assess the function of a
Right.
failed graft.
Right.
Second would be in renovascular hypertension. I think these
Right.
are the two indications, but they will come much low in your list.
Right, right. So I think he had presented that also, the captoprerenal scan for renovascular hypertension and for renal transplants also. Yes. So I think definitely the nuclear imaging is important in these two indications. All right, sir. So today we have a transplant. We have patients just waiting. So we will wind up here. And thank you all the faculty members who have joined us from outside on YouTube and Zoom. And thanks all the faculty members and residents for joining this session today. Thanks and have a good day.